Good day, fellow learners. This is your mentor, your fact check buddy, Ray Gapuz, joining you for our case discussion number 46. But before we engage into our teaching learning session for this specific case, make specific time for this pleading, please. Join us in this mission. Our goal is to provide free NCLEX RN application and review to 500 nurses, and to help us achieve this, please just watch and finish the ads in our videos. Don't skip, please. And if you share this video to at least 10 of your friends, we will pray for your success. Thank you so much. We're working on giving scholarships to 500 nurses this year, and we hope that when you don't skip our videos, as you engage or as you watch this specific case discussion, we'll get through all of those obstacles to achieve our goal for this year. And you are a part of this. Be part of the success stories of 500 nurses. Okay? So, shall we begin? Well, I received this message on my Facebook Messenger coming from a student 21 years ago who joined the class when maybe I was 2 years old. Kidding aside. Okay, this is from Tin, and she brought her kit. That was the review kit that we were giving 2 decades ago. And this is what she says. You showed us a US White House or a mansion at the beginning of your presentation. Fast forward 21 years after, sir, I would like to think na manifest ko rin. So that means to say she achieved her dream of owning a big house with a swimming pool. Just like what I did, okay? So this is what she's saying. I was just reading your website. I did take the 2005 NCLEX exam, June PNLE Top 10. Local review lang kami sa Iloilo. CJFNS, October 2004. Okay. Time frame, okay. Cebu. Then NCLEX, May 2005, Seattle. Lahat pasado. So what she's saying is that she passed everything through the system. It did make a big difference using my yellow book. That was the old book that I authored. Guide of yours plus sariling sikap. That's why I feel so strongly that yours was effective in prepping me and somehow indebted to you. And I said, thank you so much for the kind words, madam. That's Tin's success recipe. Of course, she's from Iloilo, and Madam Mugid salamat. Now, fast forward. I now have a new book, and it's called NCLEX RN 311. And some of the feedbacks that we have here are as follows. Some are saying it's like the actual, parang actual. Parang reflection po talaga ng QUICKFIX, YouTube, and 311, yung questions that I got. So happy po I got through the exam successfully. Thank you po, sir, ng madami. So she's practically saying that the questions she had on the actual test were just like a reflection of what you watch on our YouTube channel, the QUICKFIX review that we did, which is a 3-day, 24-hour review program, and reading NCLEX 311. And then, of course, we have your chin. Blank came out. I was like, Sir Ray, know what topics would come out? I'm glad I'm a Ray Gapuz baby. Thank you. And as they say it in Filipino, pato. Okay, and then somebody says it's amazing. From Vic, sincerely speaking, if it were not for NCLEX 311, I would not have passed. I went through the last 4 days to the exam. That book is amazing. Keep up the good thing of helping us nurses. Thank you so much for the very kind words. The NCLEX 311 po, the best. Halos same na same po siya sa pagkakakonstruct sa mga na-encounter ko pong mga standalone questions. What this person is saying is that the way the questions, the examples on the book NCLEX 311 were almost similar to how the questions were constructed in the actual exam. And so, let's begin our teaching and learning session for case number 46. And this is something I'd like you to remember. It's about Kernicterus, otherwise known as bilirubin encephalopathy or chronic bilirubin encephalopathy or neonatal bilirubin-induced neurologic dysfunction. As the term implies, you have 2 outstanding things that you have to focus on here. First, you have bilirubin. And second, you have encephalopathy, which gives you a clue that this is a condition in the brain that could potentially be associated with elevated bilirubin levels. First and foremost, what is the normal bilirubin level in the newborn? It depends on how long ago was the baby delivered. For those who are less than 24 hours, 6 milligrams per deciliter is usually considered normal. But for the sake of supporting your ability to memorize, you can just peg the value at 5. And when the baby is 24 to 48 hours, peg that value to 10. And when the child is more than 72 hours, peg that value to 15. So in that case, you have 5, 10, and 15. So if the baby is more than 72 hours, a bilirubin level above 15 could be considered elevated. That's a good clue. So Kernicterus is a serious complication of RH incompatibility. So let's go back a bit down our memory lane. Let's extract from our minds about RH incompatibility. Now, this condition occurs when the mother, who is RH negative, carries a child who is RH positive, in which case what happens? Well, the mother forms antibodies against the RH positive blood of the baby. Why is that so? Well, let's review a functional concept, which could be a word, a phrase, a sentence, or an entire paragraph that gives you a direction on how you should think to deconstruct a question. So the functional concept is an RH positive blood of the mom can be mixed with both positive or negative blood. Okay. And if the mother has an RH negative blood, can be mixed only with an RH negative blood. So in RH incompatibility, what happens is the mother is RH negative. And what did we say a while back? Should only be mixed with an RH negative blood. However, if the mom married someone who has an RH positive blood, in 90% of the time, the RH status of the father is carried by the fetus. So what happens now? The mother is RH negative and the baby is RH positive. And these types of blood are not compatible. So what happens? You have RH incompatibility. But the first baby is actually safe. Why? Because the antibodies produced by the mother's RH negative blood usually occurs from the time of the separation of the placenta from the uterus, because it is believed that during that time, there's going to be a mixture of the mother's and the baby's blood. Therefore, the mother's blood, which is not compatible with the baby's blood, will form antibodies. And these antibodies eventually would perceive any RH positive blood in future pregnancies to be something that's not compatible. So in essence, the RH incompatibility leads to red blood cell destruction, otherwise known as hemolysis. And when hemolysis occurs, bilirubin is released. But the increased unconjugated bilirubin overwhelms the immature liver of the baby. And so what results will be kernicterus, or in simple terms, jaundice in the brain, okay, or jaundice of the brain, or elevated bilirubin levels affecting the brain function. So kernicterus specifically refers to the irreversible or permanent brain damage caused by bilirubin toxicity. Bilirubin encephalopathy, on the other hand, is another term that describes the acute phase before permanent damage occurs. So what causes kernicterus? It's due to excessive unconjugated bilirubin brought about by rapid red blood cells destruction, because the red blood cells of the mom and the fetus are not compatible. And this unconjugated bilirubin crosses the blood-brain barrier due to severe neonatal hyperbilirubinemia, which simply means you have an elevated bilirubin levels in the blood that's at more than 20 milligrams per deciliter. Said a while back, remember the 5, 10, 15 rule. Less than 24 hours, 5 milligrams and below should be normal. 24 to 48, 10 milligrams and below should be normal. And if the baby is 72 hours and above, 15 milligrams and below should be normal. So at 20 milligrams bilirubin levels, that would definitely cross the blood-brain barrier and may potentially affect brain functioning in the baby. So what are the outstanding features of Kernicterus? You have here Kernicterus first, K, coma-like lethargy. So there's going to be extreme drowsiness or unconsciousness. Now, this is difficult to recognize because we know for a fact that the neonate would usually spend 20 to 20 hours a day sleeping. So it's very important that an expert should assess the level of consciousness of the baby. And then exaggerated reflexes, including hypertonia or later spasticity. And then rigid body arcing or opisthotonus, as you can see on the picture here. You have arcing of the back and signs and symptoms of central nervous system irritability, usually manifested by high pitch or shrill cry, and of course, tremors. And then you have ineffective feeding or poor sucking or refusal to feed, as is described by the mother. And then seizures or convulsions could occur, coupled by twitching or tremors. And of course, there's the sunset eyes, in which there's a downward deviation of the eyeballs like that. Okay, that could also be present in hydrocephalus, which could definitely tell us that there is something wrong in the central nervous system. And then respiratory distress or irregular breathing and unusual posturing like decerebrate rigidity. This is actually a posturing in which there is rigid extension of the extremities, as you can see here on the picture. Okay, so it's either arcing of the back or rigid extension of the extremities. We have decerebrate or opistotonic positioning. And then sensory neural hearing loss, which could be noticeable after a couple of months or even years. So this could be a late sign of your Kernicterus. So once again, you have Kernicterus, beginning with a K, comma. I'm sure, never mind the spelling issue. What matters the most is you are reminded what Kernicterus is all about. Okay. Now, what are the diagnostic highlights of Kernicterus? You have definitely number one, serum bilirubin that's critically high, usually above 20 milligrams per deciliter in term infants. Imaging that shows the basal ganglia is affected. So meaning there could be changes. Now, in the basal ganglia, you have the part of the brain known as your globus pallidus. This is a part of the brain that's responsible for maintaining normal movement. That's the reason why there's abnormal posturing in the child with Kernicterus, because the globus pallidus in the basal ganglia that is responsible for maintaining normal movement is affected. And then you have clinical signs of neurologic dysfunction, decreasing level of consciousness or lethargy, hypotonia, opisthotonus, or in extreme cases, seizures. And then K, Kernicterus risk factors that could be present. You have Rh incompatibility, G6PD deficiency, which is also a blood disorder, and definitely prematurity. The most outstanding there is Rh incompatibility. That occurs when the mom is Rh negative and when the baby is Rh positive. Now, the common complications of Kernicterus includes permanent neurologic damage, such as cerebral palsy, sensory neural hearing loss, or developmental delay. Now, whenever the signs and symptoms that points out to Kernicterus are present, the main nursing priority for a child with Kernicterus is to implement immediate exchange transfusion. And the purpose of that is to rapidly lower the bilirubin levels and prevent further brain damage. Now, exchange transfusion involves the following. First, small amounts of the baby's blood are withdrawn and replaced gradually with the donor blood. It's usually done over a 1 to 2 hour period. And note that the volume exchange is typically double than the infant's blood volume. So for example, if the infant has a blood volume of 80 to 90 ml per kilogram. So you have to prepare double than the infant's blood volume. So 80 to 90, multiply that by 2 to double it. So it's going to be 160 to 180 ml per kilogram of body weight. And then it involves continuous monitoring of vital signs, glucose as well as electrolytes and calcium. And we need to watch for complications like a decreasing heart rate or bradycardia, decreasing sugar levels like hypoglycemia, and the occurrence of electrolyte imbalance, and definitely infection. That's why the temperature of the child must be carefully monitored. Now, the next question is, how much blood is withdrawn in exchange transfusion? So here's an example. So if the total blood volume of a newborn is approximately 80 to 90 ml per kilogram of body weight, double the volume for exchange transfusion. So multiply 80 to 90 by 2, so you'll get 160 to 180 ml per kilogram, and that's what's being exchanged. So for a 3 kilogram newborn, all you have to do is to multiply the weight with 85 ml, which is the approximate blood volume, okay, per kilogram. So you multiply that by 3, you will get 255. However, if you're going to prepare for exchange transfusion, you have to double 255 ml. So if you multiply that by 2, you'll get 510 ml. That's the total that's being exchanged. And this is done in small aliquots. Aliquots meaning small portions of a total part, okay? So like, for example, 5 ml per cycle in preterm infants and 10 ml per cycle in term infants. And this procedure is usually done in 1 to 2 hours, okay? So before we go on to use what we discussed in terms of the functional concepts that I highlighted to answer a case study, let me first share with you the success story of the world's oldest next generation NCLEX RN passer. Her name, Madam Flor Villarreal from Naga City, Bicol region in the Philippines. And she passed NGN at the age of 66, and she just turned 67 last May. Okay, so what made her pass? It's the functional concept. So let's use the functional concept to answer a case study. Okay, once again, Mami Flor Pangilinan Villarreal from Ago Foundation College, congratulations. So here's case number 46. A 3-day-old full-term male infant presents to the emergency department with poor feeding, lethargy, and high-pitched cry. Those group of symptoms, otherwise known as syndromes, should tell you there's something wrong with the baby. The first thing that you would see that a baby is sick is that there's poor feeding or they're unable to feed. And then you have decreased level of consciousness, the baby becomes lethargic, and the characteristic shrill cry or high-pitched cry. We all have it here. First sentence. You're lucky if you'll find a question such as this. The mother reports the baby has been increasingly deeply sleepy and difficult to wake with noticeable yellowing of the skin and eyes. Now, this is a little tricky because if you talk about pathologic jaundice, it is jaundice that occurs less than 24 hours after the baby's delivery, which tells us that there has been red blood cell destruction or hemolysis from the time the baby's inside the uterus, and it became obvious when the baby was born. However, do not focus on the age of the child in relation to the jaundice, but rather focus on the central nervous system group of symptoms like poor feeding, lethargy, and high-pitched cry. And then read further. On examination, the infant shows hypotonia, intermittent arcing of the back or opistotonus, and sun-setting eyes. Now, even if yellowing of the skin, the eyes could be considered as physiologic jaundice after the first 24 hours after birth, the fact that you have several symptoms that tells you there's potentially an affectation of the central nervous system, we cannot just solely rely on the fact that you have here a 3-day-old full-term newborn with yellowing of the skin and the eyes, because in normal circumstances, that could be misinterpreted as physiologic jaundice. However, the laboratory tests reveal a serum bilirubin level of 28 milligrams per deciliter. That's the clincher. If you know your normal bilirubin level. Once again, you have your 3-day-old full-term infant, which simply means our maximum value for the serum bilirubin level that could be considered as normal should be 15. However, you have almost double that value in this case, 28. So which simply means that there's elevated serum bilirubin. And by definition, kernicterus occurs when the serum bilirubin level, meaning the level of bilirubin in the blood, is more than 20 milligrams per deciliter. So let's answer the question. Which intervention should the nurse anticipate? Is it one, administer oral iron supplementation? Now, number one is the intervention for iron deficiency anemia, which could also be present in babies who are overfed with milk, because milk is a poor source of iron, but that's not what the case contains at the moment. So to prepare the infant for exchange transfusion, we can consider it's one of those functional concepts we discussed a while back. 3, initiate intravenous antibiotic therapy. There's no presenting symptom that would tell us that the main problem is about an infection. Okay. And 4, teach the mother how to properly latch during breastfeeding. It could be a concern if your baby is normally as it is. However, if the baby is manifesting several signs and symptoms that would point out to a potential abnormality, option 4 is definitely not the answer. So based on the functional concepts that we discussed, the best answer would be to prepare the infant for exchange transfusion. Okay? And I'd like to invite you, if you want more learning such as this, please do visit us and use the only near the real field of the next generation NCLEX RN simulator at the Ray Gapuz Review System building, second floor, United Nations Avenue, Alhambra Street, Manila, Philippines. But for those of you who are accessing our programs from the different parts of the world, please do get in touch with us, and we'll definitely allow you to have that near NGN type test field. Okay, this is also our next generation NCLEX classroom, where we usually conduct our QUICKFIX. It's a 3-day program with me all throughout. Okay, and this is our main hall where we conduct our larger classes, and we're proud to show you that we have very clean restrooms because we care for your comfort. We believe that learning best occurs in a comfortable environment, and we also have a student lounge for everyone. We can have coffee and juice, and that's free-flowing all throughout the day. Okay, so may I invite you, for those who want more of these videos, to please subscribe to my YouTube channel. We're now more than 27,000 subscribers. My goal is to increase that to 100,000, and that's NCLEX Ray Gapuz. We have a promo for those of you who are looking for some budget programs. You get a free review from us if you process your NCLEX RN application with ITAPS Gapuz, our official processing partner. So next gen NCLEX application processing with free review, all you have to do is to call ITAPS 0955-658-5891. Once again, this is your mentor, your fact checker buddy, Ray Gapuz, joining you in another meaningful teaching and learning moment, and see you in my next video.